Welcome back everyone. Now we'll discuss pre-excitation syndromes, focusing on AV reentrant tachycardia, AVRT, and Wolff-Parkinson-White syndrome or WPW syndrome, as well as the mechanisms of reentry. Let's begin with the diagrams at the top of the page. The left figure demonstrates the mechanisms of AV nodal reentrant tachycardia or AVNRT. In some individuals, the AV node contains two pathways: a slow pathway which conducts impulses slowly but has a short refractory period, and a fast pathway which conducts rapidly but has a longer refractory period. Normally, both pathways conduct without causing problems. However, if an atrial premature beats occur, the fast pathway may still be refractory while the slow pathway is ready to conduct. The impulse therefore travels down the slow pathway, and by the time it reaches the lower common pathway, the fast pathway has recovered. The impulse then travels backward through the fast pathway, creating a continuous re-entry circuit that produces AVNRT. The figure on the right illustrates an accessory pathway known as the bundle of Kent, which is responsible for Wolff-Parkinson-White syndrome. This pathway bypasses the AV node and allows part of the ventricle to be activated earlier than normal. On the ECG, this early ventricular activation appears as a delta wave, which is a slurred upstroke of the QRS complex. Pre-excitation syndrome. These are a subgroup of supraventricular tachycardias caused by an accessory pathway that leads to premature activation of ventricles. AV reentrant tachycardia, AVRT. AVRT is a re-entry tachycardia involving both the normal AV conduction system and an accessory pathway. It commonly occurs in patients with WPW syndrome, although concealed accessory pathways that conduct only in the retrograde direction can also produce AVRT without showing a delta wave on the ECG. Treatment. Treatment during an acute episode is similar to AVNRT. However, long-acting AV nodal blockers such as digoxin and verapamil should be avoided, particularly in patients with WPW. For recurrent episodes, catheter ablation of the accessory pathway is the definitive treatment. Antiarrhythmic medications such as flecainide or procainamide may also be used when appropriate. Wolff-Parkinson-White syndrome, WPW. Wolff-Parkinson-White syndrome is a congenital condition occurring in approximately 1.5 to 2 people per 1,000. The hallmark is the bundle of Kent, an accessory conduction pathway connecting the atria directly to the ventricles. Because electrical impulses bypass the AV node, ventricular depolarization begins earlier than normal. This early activation produces the classic ECG findings, such as short pure interval less than 120 milliseconds, delta wave, which is this slurred upstroke of the QRS complex, wide QRS complex due to premature ventricular activation, and secondary ST segment and T wave changes. Patients with WPW are prone to tachyarrhythmias, most commonly AVRT and atrial fibrillation. There are two forms of AVRT in WPW. Orthodromic AVRT is the most common. The impulse travels down the AV node and back up the accessory pathway, producing a narrow QRS complex because ventricular activation occurs through the normal His-Purkinje system. Antidromic AVRT is less common. The impulse travels down the accessory pathway and returns through the AV node, resulting in a wide QRS complex because the ventricles are activated entirely through the accessory pathway. To summarize, pre-excitation syndromes are caused by accessory pathways that bypass the AV node. AVRT is a re-entry tachycardia involving both the normal conduction system and an accessory pathway. WPW syndrome is characterized by the bundle of Kent, producing the classic ECG triad of a short peer interval, delta wave, and widened QRS complex. Recognition of these ECG findings is essential because management differs from other supraventricular tachycardias, and catheter ablation provides a highly effective definitive treatment for symptomatic patients. AFib in patients with Wolff-Parkinson-White syndrome. Atrial fibrillation is the most common arrhythmia in up to 20% of patients with Wolff-Parkinson-White or WPW syndrome. Unlike typical AFib, impulses in these patients can travel through the accessory pathway bypassing the AV node. Since the accessory pathway does not slow electrical conduction, the ventricles may be activated at extremely rapid rates, often greater than 200 beats per minute, producing a wide QRS complex known as pre-excited AFib. This condition is dangerous because it can rapidly deteriorate into ventricular fibrillation and sudden cardiac death. The acute treatment includes electrical cardioversion if the patient is unstable. In stable patients, procainamide or intravenous amiodarone may be used. An important exam point is that AV nodal blocking agents should be avoided, including digoxin, beta blockers, calcium channel blockers, and adenosine, because they increase conduction through the accessory pathway, potentially triggering ventricular fibrillation. The defective long-term treatment is catheter ablation of the accessory pathway. The figures on the right compare orthodromic AVRT, where conduction travels down the AV node and returns through the accessory pathway, producing a narrow QRS, with antidromic AVRT, where conduction travels down the accessory pathway and returns through the AV node, producing a wide QRS complex. Ventricular tachyarrhythmias. Let's now move on to the ventricular tachyarrhythmias, beginning with premature ventricular contractions or PVCs. Premature ventricular contractions or PVCs are early ventricular beats characterized by a wide QRS complex greater than 120 milliseconds, no preceding P wave, and an abnormal or bizarre QRS morphology. The morphology helps localize the origin. A left bundle branch block pattern suggests a right ventricular origin, while a right bundle branch block pattern suggests a left ventricular origin. Although PVCs are often benign, they become clinically significant when they occur frequently in consecutive runs of 3 or more beats, arise from multifoci or fallen on the T wave of the previous beat. The classic RN on T phenomenon, which may trigger ventricular tachycardia or ventricular fibrillation. The risk depends mainly on the patient's underlying heart disease, such as myocardial infarction or heart failure, rather than on the PVCs themselves. Treatment begins with a lifestyle modification, including reducing caffeine, alcohol, and stimulants use. Patients with persistent syndromes or structural heart disease may require beta blockers, antiarrhythmic medications, or catheter ablation. The ECG illustration compares a PVC, which has a wide premature QRS without a preceding P wave, with a premature atrial contraction, or PAC, which originates above the ventricles and has a narrow QRS. Accelerated idioventricular rhythm. Accelerated idioventricular rhythm is an ectopic ventricular rhythm with a heart rate between 50 and 100 beats per minute. It commonly occurs after acute myocardial infarction, especially following reperfusion therapy, and may also be seen in cardiomyopathy, hypertension, or valvular heart disease. This rhythm is generally benign, often occurs during sinus bradycardia, is easily overdriven by a faster supraventricular rhythm, and usually requires no treatment. Ventricular tachycardia. Ventricular tachycardia, or VT, is defined as 3 or more consecutive ventricular beats with a rate typically between 140 and 200 beats per minute. When the rhythm lasts more than 30 seconds, it is called sustained VT. Typical ECG findings include a wide QRS complex, AV dissociation, and a bizarre QRS morphology. Additional clues favoring VT include capture beats, fusion beats, extreme axis deviation, and concordant QRS complexes across the precordial leads. Even non-sustained VT lasting less than 30 seconds is clinically important because it predicts a higher risk of future sustained VT, stroke, and mortality, particularly in patients with structural heart disease. Monomorphic ventricular tachycardia. Monomorphic VT consists of identical QRS complexes indicating a single ventricular focus or re-entry circuit. It is more common than polymorphic VT and may degenerate into ventricular fibrillation. Common causes. Common causes include previous myocardial infarction with a scar formation, cardiomyopathies, myocarditis, arrhythmogenic right ventricular dysplasia, certain drugs such as cocaine, electrolyte abnormalities, or it may occasionally occur without a structural heart disease. Polymorphic ventricular tachycardia. In polymorphic VT, the QRS morphology, amplitude, and the axis continuously change because the ventricular rate is usually 200 to 250 beats per minute. Patients are more likely to become hemodynamically unstable. Causes include acute myocardial infarction, severe ischemia, hypertrophic cardiomyopathy, dilated cardiomyopathy, myocarditis, congenital heart disease, WPW with antegrade accessory pathway conduction, electrolyte or acid-base disturbances, and conditions causing QT prolongation such as torsade de ponta. To conclude, AFib in WPW syndrome is an emergency because rapid conduction through the accessory pathway may cause ventricular fibrillation. Avoid AV nodal blockers and treat with cardioversion or procainamide followed by catheter ablation. PVCs are usually benign but become concerning when frequent, multifocal, or occurring as R and T beats. Accelerated idioventricular rhythm is usually a benign post-MI rhythm that rarely requires treatment. Ventricular tachycardia is a life-threatening wide complex tachycardia distinguishing monophonic from polymorphic. VT helps identify the underlying cause and guides appropriate management. Now let's begin with the treatment of ventricular tachycardia or VT. Sustained VT, defined as lasting more than 30 seconds, is considered a medical emergency and requires immediate treatment. If the patient is hemodynamically unstable, meaning they have hypotension, altered mental status, chest pain, or signs of shock, immediate synchronized electrical cardioversion should be performed following ACLS guidelines. If the patient is hemodynamically stable, treatment options include synchronized cardioversion or antiarrhythmic medications such as amiodarone, procainamide, or quinidine. Patients who survive sustained ventricular tachycardia or ventricular fibrillation and have structural heart disease without a reversible cause should be evaluated for implantation of an implantable cardioverter defibrillator or ICD to prevent sudden cardiac death. Now let's discuss how to differentiate ventricular tachycardia from supraventricular tachycardia with aberrant conduction. Clinically, symptoms alone are not reliable because both conditions may present with palpitations, dizziness, or syncope. However, several clues strongly favor ventricular tachycardia. A history of coronary artery disease or previously myocardial infarction is highly suggestive of VT. Physical examination may reveal Cannon's A waves due to atrioventricular dissociation, and variable intensity of the first heart sound may also be present. If carotid sinus massage or adenosine terminates tachycardia, the rhythm is most likely to be supraventricular in origin. On the ECG, several findings support the diagnosis of ventricular tachycardia. These include AV dissociation, capture beats, fusion beats, a QRS duration greater than 140 milliseconds, extreme axis deviation, and positive or negative concordance across the chest leads. In polymorphic ventricular tachycardia, the QRS axis changes continuously during the arrhythmia. An important clinical pearl. An important clinical pearl is that in patients older than 65 years with previous myocardial infarction or structural heart disease, a wide complex tachycardia is ventricular tachycardia until proven otherwise. Other causes of wide QRS tachycardia include supraventricular tachycardia with aberrant conduction, pre-existing bundle branch block, atrial tachyarrhythmias conducted through an accessory pathway in Wolff-Parkinson-White syndrome, and antidromic AV reentrant tachycardia. Let's discuss torsi di ponta. Torsi di ponta is a unique form of polymorphic ventricular tachycardia that occurs in patients with a prolonged QT interval. The ECG demonstrates the classic twisting of the points where the QRS complexes rotate around the baseline while continuously changing in amplitude and axis. This arrhythmia often begins after a pause, making it a pause-dependent rhythm, and usually occurs at ventricular rates between 150 and 300 beats per minute. The major causes include congenital long QT syndromes and acquired QT prolongation. Acquired causes are commonly due to medications such as class 1A antiarrhythmics like quinidine, class 3 agents such as sotalol, tricyclic antidepressants, phenothiazines, erythromycins, quinolone antibiotics, and antihistamines. Electrolyte abnormalities. Electrolyte abnormalities, particularly hypokalemia and hypomagnesemia, are also important causes, as are nutritional deficiencies that lead to electrolyte disturbances. Treatment consists of intravenous magnesium sulfate, correction of potassium and magnesium deficiencies, temporary overdrive pacing or beta blockers when indicated, and discontinuation of any QT prolonging medications. If the patient becomes hemodynamically unstable, immediate electrical cardioversion or defibrillation according to the ACLS protocols is required. Finally, let's review ventricular fibrillation. Ventricular fibrillation is the most dangerous cardiac arrhythmia. And instead of coordinated ventricular contractions, there's a completely chaotic electrical activity producing irregular fibrillatory waves with no recognizable QRS complexes. Because there is no effective ventricular contraction, cardiac output immediately falls to zero, making ventricular fibrillation a cardiac arrest rhythm and one of the leading causes of sudden cardiac death. Without prompt treatment, ventricular fibrillation is rapidly fatal. Management follows the ACLS cardiac arrest algorithm and includes immediate high-quality CPR, rapid defibrillation, airway and ventilation support, and appropriate medications during resuscitation. To summarize, sustained ventricular tachycardia requires rapid assessment and treatment based on hemodynamic stability. Wide complex tachycardia should be assumed to be ventricular tachycardia unless proven otherwise. Torsade de Ponta is a polymorphic ventricular tachycardia associated with prolonged QT interval and is treated primarily with intravenous magnesium and correction of underlying cause. Ventricular fibrillation is a cardiac arrest rhythm requiring immediate CPR and defibrillation to maximize survival. Now let's discuss sudden cardiac arrest, a true medical emergency in which the heart suddenly stops generating effective electrical activity leading to loss of circulation. In definition, sudden cardiac arrest is defined as the cessation of cardiac electrical activity resulting in circulatory collapse. Patients suddenly become unresponsive, lose their pulse, and may have gasping respirations or non-spontaneous breathing. The presenting rhythm is most commonly pulseless electrical activity or PEA, asystole or ventricular fibrillation, and less commonly pulseless ventricular tachycardia. Etiology. The likelihood of an underlying cardiac cause increases with age. In older adults, cardiac disease is the most common cause, whereas in children and adults younger than 35 years, non-cardiac causes become relatively more common. The cardiac causes include myocardial ischemia, such as STEMI, NSTEMI, coronary artery spasm, coronary dissection, and anomalous coronary arteries. Ischemic cardiomyopathy, including heart failure and myocardial scar. Non-ischemic cardiomyopathy, including dilated, hypertrophic, infiltrative, arrhythmogenic right ventricular cardiomyopathy, hypertensive cardiomyopathy, and HIV-associated cardiomyopathy with left ventricular failure. Valvular heart disease, especially aortic stenosis and mitral regurgitation. Heritable ion channel disorders such as long QT syndrome and Brugada syndrome. Primary arrhythmogenic disorders including acquired QT prolongation, idiopathic ventricular arrhythmias, complete heart block, and Wolff-Parkinson-White syndrome. Congenital heart disease such as tetralogy of Fallot, ventricular septal defect, and postoperative surgical scars. Important non-cardiac causes include vascular disorders including pulmonary embolism, aortic dissection, aortic rupture, and stroke. Neurologic conditions such as sudden unexplained death in epilepsy and neurogenic causes. Hemorrhagic causes including subarachnoid hemorrhage, intracranial hemorrhage, and gastrointestinal bleeding. Infectious causes, particularly sepsis and pneumonia. Respiratory causes, including respiratory arrest and tension pneumothorax. Other causes include substance overdose, diabetic ketoacidosis, and trauma. Management. Management begins immediately with advanced cardiac life support or ACLS. High-quality chest compression and yearly activation of emergency medical services are essential. Patients are managed differently depending on whether they have a shockable rhythm, such as ventricular fibrillation or pulseless ventricular tachycardia, or non-shockable rhythm, such as PEA or asystole. After return of spontaneous circulation, the focus shifts to identifying the underlying cause. Investigations include coronary angiography, electrophysiologic studies, and echocardiography. Patients with ST segment elevation require emergent coronary angiography and vascularization. Even patients without ST elevation may still have significant coronary artery disease and should be considered for coronary angiography and on a non-emergent basis. Targeted temperature management should be initiated in appropriate patients to improve neurological recovery after cardiac arrest. Further treatment includes correcting underlying cause using antiarrhythmic medications such as amiodarone, lidocaine, and beta blockers, and considering an implantable cardioverter defibrillator or ICD for secondary prevention in patients at high risk of recurrent ventricular arrhythmias. Electrophysiologic studies. Finally, let's discuss electrophysiologic studies or EPS. EPS is an invasive procedure that uses in-cardiac catheters to investigate and treat cardiac rhythm disorders. It provides a detailed analysis of the mechanism and exact origins of arrhythmias, particularly when the surface ECG findings are inconclusive. For bradyarrhythmias, EPS can evaluate sinus node dysfunction and localize the site of atrioventricular conduction block, although this indication is less commonly performed today. For tachyarrhythmias, electrophysiologic studies are used to map arrhythmias before catheter ablation and to assess the inducibility of ventricular tachycardia, particularly before implantation of an ICD. Remember these high yield points. Sudden cardiac arrest presents with loss of pulse, unresponsiveness, and absence of gasping respirations. Common presenting rhythms are PEA, asystole, ventricular fibrillation, and pulseless ventricular tachycardia. Immediate high-quality CPR and ACLS are the cornerstones of management. After resuscitation, identify and treat the underlying cause, consider coronary angiography, initiate targeted temperature management, and evaluate the need for an ICD. Electrophysiologic studies play an important role in diagnosing complex arrhythmias, guiding catheter ablation and risk stratifying patients for ventricular arrhythmias. Thanks for watching. If you're new to the channel, please like and subscribe and press the bell icon. See you in the next videos.